All right, I'm going because I was not surprised that Joia draws this fantastic crowd. I'm Podolsky. I get to help work the seminar series, and it's super honored to have Joia today. Joia is obviously someone who really needs no introduction and certainly inspiration to so many of us. She's Associate Professor of Medicine and Associate Professor of Global Health and Social Medicine here at HMS and the Brigham. She's a graduate of the University of Minnesota Medical School.
Go Gophers!
Trained in internal medicine, pediatrics, and infectious diseases at MGH, and obtained her master's in public health from the Harvard School of Public Health. In 2000, she served as the Chief Medical Officer for IH, as an advisor, expert consultant on global health system strengthening for organizations ranging from the WHO, the National Ministries of Health, to NGOs like Last Mile Health in Nigeria, Village Healthworks in Burundi, and Muso in Mali. She directs the Master of Medical Science Global Health Delivery Program, as well as the program in Global Medical Education and Social in our department. So I sincerely can't think of anyone more qualified to write a book on global health delivery, especially one with the subtitle Practice, Equity, Human Rights, than Joia. And I'm thrilled we'll get to a preview of her forthcoming book and consider it as part of the launch party. So Joia,
hey, this is a launch party. Thank you so much, and a special thanks to Scott for inviting me. I just didn't really think about it. This is a textbook. It's supposedly geared toward undergrads, but I'm hoping that graduate students, medical students, and other people who are just interested in global health will also appreciate that. Can we turn on just a light up here because I want to read something from the book to begin. So this project took exactly a year and a half. So I was approached by Oxford University Press in May of 2016 to write an undergraduate book on health, and I said no. I have 3 jobs, I'm too busy, and they said, please. It turns out that global health is the #1 undergraduate minor, which I did not know. And so there are people who are engineers, who are statisticians, who are nurses, who are many different undergraduate sort of life who are minoring in global health. Interestingly, they're not minoring in public health. They're minoring in global health. And so I wrote a prospectus at the urging of this editor, and it got ripped apart because, of course, as in all academic things, they send it to your editors. They send it to the 3 people who have textbooks on health, who said we don't need another textbook on health. So I was relieved and done. And this editor, who's really wonderful, he said, please, just write it back like you would respond to journal, and we'll get them to accept it. And what I said was the fund delivery unique. That as medical professionals, whether you're in nursing, whether you're in medicine, whether you're a psychologist, whether, as people who care about delivering care to the sick, global health is a totally new discipline. I looked at, having read the 3 main textbooks, they're very much focused on public health. A lot of epidemiology, a lot of biostatistics, and this is all very useful information, but it's not what a lot of young people want. So I interviewed a lot of college students, people I know through PIH, people I know through family members, since I'm an old mom. Most of my kids 11, but most of my friends have kids in college. Many of them having a minor in global health. And I really decided, okay, I got to write this book. So they accepted, and they gave me a year to write it. And thanks to Gala, Sarriera, and the department for giving me a research assistant, because there was no way, Debbie Brace, who's now in medical school, Vincent Lin, who was my summer intern, Emil Ling, without these worker bees, there would have been no way. So I'm going to just read you from my acknowledgments, which includes so many people. I'm not going to read the list of acknowledgments, but suffice to say, at least Maxby plays prominently in them, and many of you do as well. But I want to read you from this acknowledgments because this book is really not dedicated to any one person. It's dedicated to the team of trying to right injustice, and also to the patients that we have failed over the years. Stunned silence, I watched lovely die in front of me. Her bloated belly, rare and swollen feet screamed the medical diagnosis kwashiorkor, 13-calorie malnutrition. Heartache, anguish, and even shame on her mother's face pierced my psyche. Cynthia, Lovely's mother, took her child to every weigh-in. Vaccinations were all up to date. The little girl died, however, under the watchful eye of a child survival program. Only healthcare available to children in impoverished countries throughout most of the late 20th century. These twice-yearly campaigns provide monitoring, vaccinations, deworming, oral rehydration salts, and vitamin A to children under 5 years of age. I once volunteered in such a child survival program. I lovely. Recorded her weight on a growth chart. I held the multicolored chart of the 4 food groups in hands and educated her mother on proper weaning foods to give lovely. Meat, eggs. But I knew did not have food. She didn't own land. She didn't have money. Children do not die of starvation because of the mother's ignorance. Mothers, when their children are hungry from their ceaseless cries, they and their children are dying of starvation when the crying stops. More than 25 years ago, I first witnessed death from starvation. In my ignorance, my relative solitude, I delivered the prescribed health education only to Cynthia and to others. But I did not make sense of a world where a starving child was not offered food. I felt ashamed then and now at the inequity of a world with enormous wealth and starved children. Health disparities are a thermometer of injustice. The world in which I once lived focused only on health education and prevention. Treatment was not given. Doctors blamed Lovely's death on her mother's ignorance of the proper weaning foods to give Lovely. By standards, Sarah was blamed for contracting the human immunodeficiency virus because she did not demand condoms from her sexual partners. Yet money she got for sex allowed her to feed her children for another day. Pedro was blamed for developing drug-resistant tuberculosis. Daily transportation to clinic cost him a day's wages, made his adherence to the prescribed treatment erratic. This book is for Lovely, for Cynthia, for Sarah, and Pedro. It is for the thousands of patients I have cared for who are destitute and struggle daily to survive. Their destitution is not a choice. It is not a product of bad behavior or ignorance. It is structural. It is related to the historical and present-day forces of racism, wealth disparity, militarism, gender equality, and others. Their medical conditions are severe and often lethal. Their illnesses are costly, often catastrophically so. The patients who have lived and died on my watch deserve more than prevention, more health education, and more than what is sustainable under meager budgets of the countries in which they live. People like Lovely, Cynthia, Sarah, and Pedro deserve quality, modern medical care. Care is delivered with compassion and respect for human dignity. Indeed, the destitute have a right to health. We all do. So that was my motivation for writing this book, because I know that what we all do collectively is motivating to so many young people around the world, not just in the United States. And is this gap between the previously constructed nihilistic public health programs of growth monitoring, oral rehydration, breastfeeding, immunization, GOBI, the idea of train the trainer, or TOT, which even the NGOs will say burns money in trainings rather than providing salary support for underpaid workers, the information, education, and communication campaigns that assume ignorance of the poor as the main problem, as a health problem, that rely on behavior change, even as behaviors are rooted in deep structural inequity, that talks about sustainability of health interventions on the meager budgets of poor countries, and rely on cost effectiveness, which is, as always, limited by the GDP of the country. I felt that we had to say what we think, and that's me, all of us. And one of the things I say in the book is that social justice, global health ought to be a team sport, that there is no one person who has the lock on this, and we need to work with committee members, governments, and all of us as colleagues and friends. You know, this is really, we can turn off this front light now. This is really what I learned from walking this road, and it was really shocking to me. I was a young, a medical student working in Africa doing these campaigns where literally I was doing Go, Be, and there are children that look like this. And chart them on a growth chart and send them on their way and tell the moms to eat beans, feed the kids beans. And everyone says, oh, the mothers are so ignorant. They just go from breastfeeding to mashed bananas. They weren't ignorant. They didn't have anything but mashed bananas. So, this is treatment, right? Treatment. This is a kid who got therapeutic milk, used therapeutic food, and in just, a few weeks, he's back to life. This is a deadly condition, malnutrition. It's not something that can be prevented by educating a mother. Similarly, I grew up, as some of us did, in the AIDS activist movement, and the first time I went to Africa to do AIDS work, it was all about telling girls to protect their virginity. Meanwhile, they had no money for school fees. Many of them were orphans, and one young woman said, Auntie, I would just say no. But I have no money for school. And if I don't learn to read and write, learn my math, I will definitely get HIV because I will end up as a servant. And if there's some man in my community who's going to pay for my school, I'm going to do that because I am making a choice, and I understood choice, agency, and the constraints of choice. I feel so lucky to have landed in this department because I'm not a social scientist, right? I'm a physician. I'm a public health. I have a degree in public health. I wasn't even by my nation, allowed to take social science undergrad. But it is really through the social sciences that we can really understand global health delivery and equity. And I've learned that from all of you, from Bob, from Mary Jo, from others. And thankfully that. And so a lot of the focus of this book is the care of the individual. Byron asked me to talk at the Anthropology Association a few years back, and we talked about the importance of ethnography and the importance of the single story in understanding the world. And I will just encourage all of you, and many of my grad students are here, thanks guys, and I gave you a break to study, so, I bought your time. Understanding the single story is imperative in what we do. And so I have put forward 5 principles for global health delivery in this book, and they are, I think, differentiating from the story I read in the beginning and these narrowly focused things. The first is that we deliver care to the burden of disease. We don't say, well, cancer, not in the envelope, right? Schizophrenia, not in the envelope. What's the burden of disease, and then how do we design? And I'm looking at Max because there's no way any of this would be possible without. Max taught me 90% of what I know now. He's my grad student. So I'm like the Wizard of Oz, right? You're the lion, and I'm going to give you the medal. Okay, so delivery of medical care to the burden of disease, and that is a totally different paradigm I learned in public health than is still being promoted. And we saw this in Ebola. I didn't put the slide up, but there was a young boy we saw in the height of Ebola who had a massive Hodgkin's lymphoma, 11-year-old boy. And our team, who was not a PH team, there were a lot of volunteers from all over the world. They said, "Oh, we can't do this. We don't do Hodgkin's, Ebola." And I said, "You're not going to let 10 kids die of a treatable cancer. Not on my watch. Not our watch." So we got him some palliative therapy because we couldn't get him out of the country. He survived through Ebola to end the travel ban and got him to Rwanda. Now he's cured. That is global health delivery, the burden of disease, and then hopefully designing the system long term. So implementation of programs to achieve equity. And equity means 100% of people, everybody in, nobody out, right? Equity is the goal of global health delivery. I think, so often you see that someone will, this vaccination program is great. We've vaccinated 90% of the children, but it's the 10% that we care about. It's the story of those 10%. They're orphans. They are child heads of households. The people whose parents have disabilities and schizophrenia, MDR-TB. So if we don't make our work relevant and curative for that 10%, then we've missed out on the equity agenda. The third is understanding and addressing the social determinants. This is about social medicine, social approach. And to me, so much of this is understanding history, understanding political economy. You can't go into a place and not get that. And I learned as much from Haiti as I did from Daisy. Scott. Developing a rights-based approach, and what we have really put forward as a rights-based approach is two very important pillars. One is the pillar that in human rights language people talk about a lot, which is engagement of the community. That is very important, but the arbiter of human rights in current treaties is the government, right? The government is charged with respecting, protecting, and fulfilling rights. But we know that the history of impoverishment of poor governments has made it almost impossible for governments to deliver, especially in Africa and some parts of Latin America and the Caribbean, Haiti, for one. So supporting governments to deliver on rights is a very critical part of the human rights work, because if people should demand their right to health, they have to demand it to an entity that has some power to deliver. So that's a third important principle. The fourth is developing this, the fifth is really building capacity. That this is not about parachuting in, this is about long-term engagement across many countries and people who will work together for years, decades, like with Maxie, like any of you have, that we will be a cohort. You know, I still think about my residency at the MGH, and today, I might not have seen somebody for 20 years and they say, oh yeah, we trained together at the MGH. Well, that's how we should look at global health, that this is a large and growing cohort of people who can learn from each other, whether it's between Bangladesh and Malawi, whether it's between, Lesotho and the United States. And so that's really, and that means residency programs, advanced nurse practitioner programs, that means professionalizing community health workers, build capacity in a meaningful way, not a fake train the trainer, but long-term engagement. Okay, so all of you, I'm not going to go over this in detail, but I think we have collectively in this department, in our group at the Brigham, and in the Partners in Health sites, we've worked on all of these steps of the pedagogical ladder of global health. And I think we can say this is a discipline. Global delivery is a discipline, right? We have rotations for medical students, we have residencies here and abroad, we have advanced practice from fellowships to master's degree programs. This contribution is really meant to kind of be in this piece of the early learners who really want to understand global health delivery. Although, as I said, I think because we're trying to change the paradigm, we may be using it in other spaces as well. So the book is divided into 4 sections, and again, respectful from everything I've learned from people in this department. I spent a fair amount of time on history, and I'll tell you a little bit about that. And the principles, which are about human rights, social medicine, the principles that had been, the biggest bang for the buck, utilitarian philosophies. It's a very different kind of set of principles. And the difficult work of health system strengthening, because that is what it will take to deliver care, because the health systems are quite weak because of this history. And then the last part is about activism, because there's no way we can actually effectively do this without being activists for change, because we have to really look at this as a sea change. So the first section is the roots of global health inequity, reversing tide from the AIDS treatment movement and the Millennium Development Goals. So, and these guys are, yeah, Lumumba right there. Thank you. I knew Andrew would get one. I'm a car. So we have to go back to colonialism and the liberation struggles to kind of understand how Africa became so impoverished. And so I talk quite a bit about colonialism, slavery, and the resource extraction that became the norm that built the empires of Europe and the United States. That if you don't understand the wealth that is continually extracted, and the fact that these men and many other revolutionaries, they spoke about health. They spoke about health as part of the social platform that they wanted to bring about in the post-colonial era. But they got slammed down by the World Bank. They got slammed down by the fact that the resources were owned by the the colonial masters. And so even though somebody like Patrice Lumumba thought, well, let's nationalize copper, well, we know what happened to him, right? And so the resources actually deliver healthcare, which is a very important part of the revolutionary psyche. Is that right, Andrew? You were there. He wrote for Liberation News. And this was a very important part of the revolutionary psyche, but it didn't come to be. So it's not that concept of health, right? I think it's very important. When we talk about behavior change, people don't believe in health. It's just frankly bullshit. This is a picture of the resource extraction this is from 2014. This is not old news, right? $192 billion of resources out of Africa each year, and this trickling in of $30 billion of overseas. And then people talk about Africa's dependency on aid. If we break the idea, there's nothing we can do. This is the dependency of Western Europe, the United States, on African mineral wealth. That's not even human resources. That's just minerals and profits made by multinational companies, etc. So to me, if you don't understand this, and again, this is written for undergrads. This is not as complex as my wonderful social science colleagues would write, but trying to get people to understand this dichotomy. And then I thought how, in the space of this, with health budgets of about $5 per capita, and my graduate students are very familiar with this $5 challenge. We talk about if you have $5, which most governments had under structural adjustment imposed by the World Bank, which is a private sector lens of economic development. You don't own your resources. The governments like Nkrumah, like Cabral, like Lumumba, if you want to spend public money on health, you're considered a communist. So you got then $5. What can you do? You can do essentially GOBI, gross oral rehydration, a promotion of breastfeeding immunization. And for those of you who have walked into a public facility anywhere in Africa, many places in Haiti, some places in Latin America and Asia, what you see is of sachets of oral rehydration salts, a small propane fridge with a UNICEF stamp on it with vaccinations, and some posters for IEC. Who's seen that? That's a very common, just go in the back room, right? Go in, and sometimes it's a closet. They don't even need space because they have one box of ORS. So it's this kind of criminal thing. And for me, it was, I worked in Africa when I was young, and then going in and thinking, what? I'm a doctor. There's nothing I need here. Not a syringe, not a glove, nothing. Not even one glove. Forget two gloves, right? So this is kind of where we were in the 90s. And human resources totally underpaid. Our colleagues were selling radios in the market or trying to do something else to pay their salary because they couldn't afford to work in the public sector. These buildings are crumbling. They're falling down. There's no recurrent cost for maintenance. Many facilities don't have electricity. They can't pay the bills for the generator, even if they're a county hospital. And the supply chain is totally broken. So there's no way to get drugs. So this is basically what fits so nicely with the 1979 paper was Selective Primary Health Care by Washington Warren. And the 1978 conference in Almanac is nice, but it's not feasible, it's not possible. Let's do this instead. For more than 20 years, this is the norm. So many of us worked in this. I did GOBI, right? And so I feel like I'm going to hell, and I want to prevent the next generation from doing that and doing, right? Change, activism, plain and simple. Nothing else changed this, not data, not humanity, nothing. Activists standing up and saying, you know what? We AIDS drugs in the United States, the birth of disease in sub-Saharan Africa, and there was no movement in 96, 97, 98, 99, 2000, 2001, that's 7 years with no movement to bring antiretroviral therapy to the continent of Africa. And in 2001, there were fewer than 50,000 people on the African continent receiving antiretroviral therapy, and it was thought to be not sustainable, right? It's not possible. Do IEC, do prevention, tell people not to have sex, and we all know, as the problem of sex, that doesn't work that well. When we lost it. Come back on. So I'll keep going. So what happened? Well, activists won, and was very fortunate to have been and still an HIV activist. But Partners in Health, we positioned ourselves with Mukherjee and Fernay and others to be part of this movement by actually showing it could be done in Haiti. And we provided antiretroviral therapy for a handful of patients in Haiti, and we became part of the movement. And some of you have seen the documentary that kind of features that story. But you know, people like Zaki Ahmed, this was a gay man with HIV in South Africa. He was a very strong anti-apartheid activist. He became an HIV activist. The organization he founded shut down the government, right? It shut down the International AIDS Conference. He himself said, I am not going to take HIV meds until they are publicly available in my country, the human rights approach, right? So a civil society approach of him fighting, but also the idea that has to be public provision of HIV care. And that created the Global Fund, PEPFAR, and a whole new era of care. Because if you can provide longitudinal AIDS care, you can do a lot of other things. Because you labs, you need labs, you need drugs, you need space, you need people, right? Staff, stuff, space systems, which Paul says, but Fernay started that. And this was published from the Lancet. And you know, this is around times when I met Rifat Atun at WHO, and we were trying to say, what are the synergistic effects of this on these moribund health systems? And Rifat's work was very informative and started to propose what ought to be the building blocks of a health system, because really, in a lot of cases, there was no health system before that. So this is work that Maxie knows well. This was us. We said HIV was our battle horse. But the battle was never about HIV for Partners in Health or for any of us. It was using the interest, the money, the enthusiasm for AIDS, and in this new era, to provide primary health care and secondary health care population. So we used AIDS money. This is a public clinic in Bukankre, Haiti. It's basically shuttered, as you can see. This is midday. Right now, I didn't control for the rainbow awning, and so I'm glad Megan's not here. But if we assume that they didn't all come forward for the rainbow awning, this is what we did. 4 things with HIV money, right? Our case-finding strategy in the public sector. We're going to use this money to revitalize the public sector because we understand that the impoverishment of the public sector was intentional, historical, and ongoing. So we said we're going to use this subversively to undo structural adjustment, undo the sort of idea that black people, brown people, poor people shouldn't get health care. They should just get prevention. So we did 4 things. So this is our voluntary counseling and testing strategy. Primary care. That's our strategy. So we said we're going to put essential drugs, like not AIDS drugs, but lots of drugs, right? We're going to hire and pay the staff, and sometimes it's paying public staff who have been working for peanuts for years. We'll reduce the barriers to care, which are user fees, again, promote in that era of structural adjustment, but in the Bamako initiative, we're going to reduce them, we're going to provide transportation, we're going to help, and we're going to hire and train an army of community health workers that may active case finding, follow people, and bridge some of this huge geographic divide. And what we saw was just so shocking. These clinics, in many cases, were kind of closed. People trickle in, you know, whatever. This is daily visits, and just by doing those 4 things in public facilities, we saw that we would have 400 visits a day, right? So, yeah, and it was overwhelming. We had to manage our staff's anxiety, right? Right, until the last patient, you're going to stay until the last patient. And I said, wow, this is the positive synergy, a project that was very heavily involved in the WHO. The positive synergy was using HIV money with an architecture toward health systems. So when we talk about health system strengthening, what a lot of our students don't realize is that was a new concept, right? That's a new concept, really, that grew out of this movement. So the Millennium Development Goals sort of coincided with the success of AIDS activism. And so the world signed on to these principles, saying it's not just about HIV, it's about women's health, it's about children's health, it's about averting death from starvation. And so we said this is a strategy, this leveraging function, who Frank, our former dean of the School of Public Health, calls it the diagonal. We sometimes, we called it the battle horse. But this leveraging function of real money for an intervention to build a health system again, a quite novel approach, particularly in very poor rural areas. We saw, this is some data from our great friend and colleague, Wesley Lambert's BU master's thesis, but we saw just even basic services like vaccinations go through the roof with this approach. So we said, even your silly Goby thing, it's going to work better if you do this. So, you know, we said this is about lifting the entire system. And something that I know is near and dear to Rafat's heart. This is the WHO Health System Framework, Service Delivery, Workforce, Information Systems, Medical Products and Technology, Leadership and Governance. And these are all essentially chapters of the book. So walking through what will it take to build a systems framework, right? Because if we want to achieve improved health and equity, right, responsiveness, all of these things, we have to do this. And that's never on anyone's agenda until the 21st century, and only because of, in my view, HIV activists. Second part is the guts, right? The second part is how do we understand the patient experience? Because, again, if we build from the top down, we're actually not going to get equity. We believe that getting to equity means listening to the individual story, what the patient, and much of this comes from here. So we looked a lot at the burden of disease, and how would we address the entire disease burden? Just focus on things that are communicable. And then I spend a lot of time talking about social forces. This is a slide from actually one of our medical students, but just if you look at the difference in life expectancy between Roxbury Crossing and Back Bay Station, it is a 30-year difference in life expectancy. The ideas that I try to get across in the book, I'm not going to use the royal we, is this idea of zip code, the important risk factor for disease and for death. We spend a lot of time in medical school teaching people about genetics and about, you know, not smoking and all that stuff. We spend a lot of time in schools of public health teaching epidemiology, statistics, and yet zip code. Why? Because of the social determinants. So there's a lot about addressing them, what they are, the economic determinants, the social determinants, the determinants that have to do with racism, and all of those things that make us provide differential care across the world and in the United States too. One of my favorite of Paul's articles called Social Science and the New TB, this is a 2-page schema, but it is the journey of one single patient, and we covered this in class for the grad students, how many barriers one patient faced actually get cured, and this person ended up dying of drug-resistant TB. So at each of these steps, if you're going to design a patient-centered system to deliver equity, you've got to walk the walk of the patient. You have to understand deeply, and so it's what this idea of delivering the caregiving that Arthur's written a lot about, and the value chain that we teach a lot. And that's the health system strengthening is the third part of the book. And this is maybe a little bit more dry, but certainly absolutely necessary, which is how we have, in what I call the global health era. Well, in the book, the global health era is from 2000 to the present, for this movement for HIV treatment access. Right? Before that, we didn't really call global health in the same way, so I'm defining it as that era and the delivery of care. So if you're going to deliver care, then you need the human resources. I dig out community health workers, which would be a little controversial. We can talk about that. Talk about the evolution in drug access. Some of us, like Chris Noble here, is on the universities aligned with essential drugs, who talk about that important movement to improve the price of drugs, make them more accessible. And some of the ways that we use data, because it's about collecting data, how can we improve data systems and really link data to equity, right? Because all isn't equal. We can use data in a way that we will see the equity agenda. So health workforce, this is $2 billion per year of public investment that's lost. Most health workers in Africa, nurses, doctors, laboratory technicians, pharmacists are trained on the public nickel. And again, these are public, budgets that are so constrained. These are trained on, and then they flee because they're not getting paid because they don't have the tools of their trade. So again, trying to take the cost effectiveness and sustainability and really turning it on its head. Who's benefiting from those public investments. Manchester, England. It's Massachusetts, right? It's elderly people in the United States who have patient qualified nurses serving as their CNAs, right? And so we are benefiting from this brain drain. I talk a lot about the new programs, from the Human Resources for Health program in Rwanda to the MEPI program through PEPFAR and NEPI, their medical and nurse training programs that rose up parallel to this movement, because as soon as we open the doors and say, oh, we're going to provide longitudinal care, oops, we don't have the workforce, right? So about that. We talk about the need for residencies. We have, Maxie was running the Mirabelais Hospital that has 6 residencies now. Why? Because if you open that Pandora's box of the burden of disease, you need surgeons, right? You need oncologists, you need endocrinologists, and so we have to build the workforce to match the disease burden, not just keep talking task shifting down to lower and lower levels. Task shifting is great, but it's not only, it's only partially good if you need high-level care. We need surgeons, we need oncologists. So there's a lot on emerging narrative of what it will take to build a long-term health workforce that can match the burden of disease. Have broken out community health workers for the simple fact that they're still not on the public nickel. We're fighting that battle in a lot of ways, and Dan Palazuelos is here, has worked a lot on this more than anyone in this room. But looking at the whole suite of things that community health workers add, and we believe that using that community perspective is better care, not less care. So we'd not to dump tasks on this, but actually use that cadre to do active case finding and to help, particularly that equity agenda. If you're that last 10%, who's going to find them? It's not the doctor sitting passively in the office, it's the community health worker who says, this family is really in trouble. So we're trying to build in the support for community health workers as a paid cadre, as a professional cadre, and as a cadre that is critical for the equity agenda. I have a few political things in here, which anyone who knows me wouldn't be at all surprised. I talk about drug access, and I try to make global health not be about international health. This is also health here at home. If we let political forces sort of result in costing people out, then there will be no equity. So trying to show that as we look at health as a human right, we have to also think of drug access as a human right. And I give a few stories of how the fight for AIDS treatment access led us down that path, particularly student-led movements. The group of students that fought the Yale University for the patent on D4T or stabudine really was a sea change in global health, because they said a university receiving public financing from the NIH ought to have some responsibility to provide fair prices of drugs. And so the movement grew into Universities Aligned for Essential Meds, which is now a global organization that has not only fought individual universities and fought for fairer prices, but has created a set of novel ideas around a patent pool, around novel ways to finance drug discovery that would make things more open access. So that's a chapter. And then Penny for this, but the chapter on monitoring evaluation is really about how do we use data to assure equity, and how do we put the idea of data systems in the hands of regular providers? How do we make some simple tools like this one to like a logic frame to say, here are your inputs, here are your process indicators, and then how do we find out if this intervention worked? And help our colleagues around the world to accountable for outcomes, not just numbers of people got an intervention. Because previously, in the sort of much more vertical era, before what I consider the global health delivery era, if an intervention vaccinated 500 kids, that was a success. But those 500 kids, 20% of them could have kwashiorkor and good outcome. Right? And so trying to think about how we go toward actually healthy children, healthy people as the outcome. And so the last part is really, I would say, about the needed way forward. How do we take what we've learned to this part, that's first almost 20 years of this global health era, and how do we learn to move to the next level? Because the next level is really comprehensive healthcare as a human right. We're very far from that. But We've had some major wins. I mean, there are 18 million people on the planet right now who have access to HIV meds for free from the public sector. So that is a sea change, and can we catch up in other areas? We talk about universal health coverage, and Joia Mukherjee's here. As I said, it's team sport. I don't mean to be like Paul and do all these individual shout-outs, but these are real, okay? I said Paul's aren't real. This is a tool that Annie, Michaelis, Jean-Claude Mukherjee, I, and others have developed, which is just to say, what if we really want to reach 100% of people? Here's a catchment area of the town of Clevo, Liberia. How many cases would we expect of pregnancy? How many antenatal visits does that require? And then how do we build a system to that? Not to build a random system and hope people show up, but like really map out the stuff, the space that's needed to address the entirety of the burden of disease. Rifat's been involved in sort of helping us articulate this for the global community, and we're hoping to be more involved in this debate. This is when we out, and Rifat had a graduate student who worked on this, and this is in Lesotho, just taking this tool. This is in a district of 250,000. Okay, so you would expect something in the neighborhood of 30,000 deliveries a year. Okay, and no, not 6,000. Sorry. So before 73. Right, and basically zero. And Lesotho has one of the highest rates of maternal death in the world, right? So we did this. We mapped out what would be needed. How many community health workers? How many nurses? How many delivery beds? And a year of mapping that out. I think it's like the. I'm overheating. So within a year of mapping that out, saw that this massive increase in facility-based delivery to 1,700, which is awesome, but it's only 34% of the total burden. So it shows you that even doing this, you still have a long way to go. So I think that's an important message. If the projector doesn't come back, we'll just turn the light. It's coming back. Okay. So yeah, it's coming. So this 1,742, which is close to the year Columbus landed. So, sorry, it's not really. This is great. It's still not enough. So if we have a target of full coverage, this could, we could say, wow, this is fantastic. But if our goal is equity, we need to do much better. So this is kind of work that we're undergoing on what is the delivery of universal health coverage and then financing. But then we'll move to financing and talk a little bit about financing. And I'm going to show you this because I think what I want people to understand is less about the money, because we talk a lot about the GDP spent on health, like the public funds spent on health. Haiti is abysmal. But, Norway, they spend a lot of money on, Malawi, right? They're kind of similar. But when your GDP is $471, this 6% is nothing. So there's a lot of pressure on African governments to put more money into health as a percentage of their GDP. But this percentage of the GDP is really just a political signal, right? It's not meaningful money when you have set $471 per capita, right? So that's where we need foreign aid. And otherwise, the out-of-pocket expenditures start to really increase. So, I always sort of urge my students to look at the Gini coefficient as a way to look at how real is this GDP, right? If this GDP is 698, but Gini coefficient is very large, it means the effective GDP for very poor people is basically nothing. And we know that's true in Haiti, that there's a huge portion of poor people who never touch cash, right? It's just a burden. Whereas, you look at Norway, it's pretty flat, right? Most people are around this, right? So this is, we've tried to portray how you should look at health financing in different countries and understand it. So government expenditure, which is the thing that will result generally in the most equitable care, because that's the public sector and that's the rights-based approach. Nigeria is only 23%. This is about 50%. And so that means that there's going to be a much higher orange box with the out-of-pocket expenditure. And surprisingly, the life expectancy in Honduras is quite a bit higher, right? Because people have access to health these are countries with similar GDPs, right? Very similar GDPs, similar Gini coefficient, but a much higher rate of net out-of-pocket expenditure. So this is something that we try to talk about is how do we improve public financing, not just sort of general financing. The ultimate chapter is on governance. I try to take a unique lens on governance and look at governance from the perspective of the public sector, not the global overarching governance that we see, but in fact, what are the forces that are impacting ministries of health? And it is a lot of technical experts that are giving advice, generally writing norms. You have other ministries, most notably and most importantly, the Ministry of Finance, that's setting your budget, right? You've got financing bodies that are imposing things like spending caps on governments. There are legal obligations like the WTO that affect a government's ability to do different things like purchase generic drugs. Then NGOs, which often have an entirely parallel system, civil society, and then, depending on the country, a big or large or small private sector. And the healthcare people feel is really impacted by all of this. And the way we've seen success, particularly in Rwanda, is that the Ministry of Health and the governments have much more control, or exert anyway, much more control over these other bodies. So this is not in the book, but I wish it was in the book. This is what we see a lot, is government GDP for health is small. Even if the percentage is large, the effective money is small. That goes into the National Health Plan. The National Health Plan hits the district hospital health center with their staff, and this kind of ends up in a very broken system, and then the community gets more or less health care, right? We often have is a huge amount of off-budget money coming from donors. A lot of it goes into overhead, a lot of it goes to American NGOs, and that work on a neoliberal framing goes into behavior change, into the community, leapfrogging across this, consultants, six-figure consultants, usually American and European, and the trainings where they pull the resources, people away from district hospitals and health centers to sit in five-star hotels and drink tea, and we've all seen that. And then there's nobody on the front lines. We had a permanent secretary in Lesotho who was not a health guide. He took her as permanent secretary, and he went to health center. He just would drive around and show up. He was actually a pretty interesting guy. And one day he shows up at this house, no staff. And where's the staff? They said they're at a training. He said, training? There's people here. So he goes in his car, and he goes to this fancy hotel where they have training. There's 300 helpers at this training. And he said, are you people insane? And he closes the training. He's all going back to work. But a few people do that. Right? And countries who are in this position of this incredibly steep budget, they kind of take whatever is given to them. And often it is really not building this system. So what a better model is, of course, we believe is direct budgetary support. That's more of a human rights approach where you build up the public sector, but at the very least, that donors support parts of national health plans generally. And I know that this is something that REFA's worked on a lot too. Helping governments to coordinate and force and cajole donors into supporting their health plan is part of our job if we believe in health as a human right. And instead of the train the trainer, if you're going to put money into training, put in universities so that you can have significant pre-service training. This is what we think is happening through the Human Resources for Health project in Rwanda. This is going to the National University to fund residencies and practitioners to minimize overhead. Then this institution will support trainings or support increasing the staff here, and the health of the population will improve. This model works because we get the privilege of working in Rwanda, which does this and has seen some of the steepest declines in mortality in history. The last chapter is on activism, and I'll end there. And I don't think we have time for questions. I'm sorry. I just highlight a few of the important social movements besides AIDS, including the movement to stop the repeal of ACA domestically, and that to really say activism works. There's no way to keep expanding the envelope of what's possible without us having a loud voice and being willing to stand up. That's the book. I'll stop there. If anyone wants to stay, you may.
do have time for questions.
Okay, good, yeah.
For folks who want to stick around, we do have some time for questions. So,
Awesome.
wonderful.
Questions? Mary?
Fab presentation, and
Thank
it
you.
will definitely pay well with undergraduates to tell you they have these kinds of questions.
Yeah.
With I wonder if you could say more words about the ATA and how you think about the lessons learned in places outside of the United States speak to the gaps that we have
Yeah. I mean,
in the U.S.
we do not have the public provision of health care. So our health is not based on health as a human right. It's based on a sort of marketplace entry point. And Chris Noble and there are others here who have been very involved in the fight here in Mass for single payer. I don't even like to call single payer because that assumes the payer. We don't call the roads single payer roads, right? I don't call my Brookline Public Elementary School a single payer elementary school. So we changed the way we look at health toward the public provision of health care. And that's what Medicare is essentially, is the public provision of health care, although we still are sort of in the payment scheme. So I think a lot of work to do, but I do think that, looking at universal health coverage and mapping the inequalities is a very important thing to do. And we have been, John, Claude, and I, and Rifa and others are working with Rob Yates, who's a big advocate, and he and the elders are going to be in Bellevue today, talking about universal health care in the United States. So I think we should think about the U.S. as part of the globe. And, we spend a ton of money on health. We have terrible health outcomes and terrible inequity. So, I don't know a lot about domestic care, but I feel morally sort of forced to be involved in this fight because, it's hard to talk about what's happening in other countries when you don't talk about what's happening here. Questions?
Congratulations.
Thank
Really
you.
amazing.
Thanks.
This is like the 20 years back. So, I remember civic movements. There was activism, there was passion.
Yeah.
We were going to global town board meetings. People would chain themselves to railings. They wouldn't listen to meetings, or they would interrupt the meetings. I don't see that anymore. So change to really get health culture and improve global health.
I agree, Rifa. We need a movement. And I think part of the reason I was even willing to write this book was how do we inspire people? I don't know, Chris, if you want to mention, because you're involved in a couple different social movements, and you're younger than I am.
This Tuesday, we're actually having a huge multi-hundred lobby day at the Massachusetts State House. Growing capacity around single-payer, Medicare for all legislation in Massachusetts the last few months, and it's piling into legislative visits and representatives. We're also involved at the ADA repeal level. We went to D.C. and in civil disobedience, we'll call it, in the House. And that brought national attention to grassroots people to have it so that healthcare can, at least as it is, maintained, and hopefully next step will be improved.
And thank you, Chris. And, Rifa, you weren't at the little round table we had when Rob was here, but Rob was talking about how different politicians in countries have run on this. Like in Indonesia, the guy was mayor of Jakarta, basically ran on this, and then he moved up the political ladder. So I think we need to make it favorable, and I think we see this now in Maine. Maine just voted to have Medicaid expansion. So I think around the world, trying to use the political power of healthcare rights is growing. The other I always say to my students is, we don't need a majority to win. Like, number of people who are changing themselves, we know them, right? It's a small group of people. The people who are the most forceful advocates in the fight against the repeal of ACA were disabled people who were in their wheelchairs on the evening news getting hauled out, and so I think there are people who are willing to stand up, and then what can we do as maybe academics to support them with scholarship that will buttress their theories, or, with using our own voices, so.
I see the next book.
Yes. Question? Yes.
I was just curious, why did you decide to spend your time on this project working towards an audience of undergraduates versus writing another high-impact journal article? The issue is topic.
Yeah. That's a question. First of all, because I was asked to do it. I mean, I wasn't like sitting around thinking, wow, I want to write an undergraduate book. I really wasn't. And I really was very reluctant, kind of dragged into it a little bit. I'm passionate about teaching. I believe greatly in the next generation. I think they are much smarter and more open to change. And, you know, I think it doesn't preclude you from writing high-impact journal articles. I'm not a big high-impact journal person. I haven't written a lot of high-impact journals. So, and then it's
High-impact to whom?
right, I guess the other question is high-impact to whom, right? The article I'm most proud of really was a viewpoint piece in The Lancet that was written in 2001, and it was despised by the academic community because it wasn't sustainable, it was a low impact, you know, but it was used by activists. So, I mean, I think for me, I'm an academic with a small a. Like, I'm privileged to be here. I'm glad, but like at the end of the day, I want poor people to get health care. And so I hope if we can, you know, inculcate the next generation in equity and justice. You know, I used to teach classes, and many of you have at the School of Public Health, the med school, elsewhere, and people, the first question is that sustainable? People don't ask that anymore. Right. So there's a sea change among young people to say, it's expensive, it's whatever, how do we make it happen? I'm much more of an activist. My capital A is for activists, my small a is for academics. JC.
So, thank you, Joia. You know, I can't say much about it. My question is, I'm trying to the audience, actually, my question is reflecting on undergrads.
Mm-hmm.
Do you think the public undergrads outside the developed world as part of their audience? Because I'm looking at, if I've had a chance to study some of this stuff, I studied in Rwanda. Yeah. And so that's also, when we say global health, it also helps us define what that means. It means like people working with other countries from
together. How do you work together? Yeah.
We teach undergrads. We try to disseminate this to undergrads also in Haiti.
Yeah.
They can learn this. Undergrads in Rwanda, so they can see or Congo or somewhere. Yeah. They can even see what, like, open their eyes and see this stuff. So
I hope so. But look, I know as I'm a Marxist, this is market capitalism. Looking at their market share. The reason they wanted to do this book is they see a lot of demand. So the question is, how do we make this available to people who aren't going to pay the cover price of $50? I don't know what the strategy is, so we need to think of that. I think we're doing photocopy. We also are putting up a YouTube channel of different lectures. If anyone want to, you know, participate, PDF, YouTube. And so I'm passionate about that, JC, because not only do I think everybody needs this information, and my graduate students can tell you that for a lot of people, let's say Joseph, you know, Joseph Siaka works for the Ministry of Health in Liberia. He knows this already, but to actually see it in print, it's like, oh, thank God. Right? He's dealing with donors who are saying, you know, do IEC, and he's saying, but I can't pay my nurses, right, Joseph? So, I mean, like, I think we need to get this information out, and how we're going to do that, I don't know, but I'm open to ideas. Yeah.
I think the perfect thing for undergrads, I've been teaching undergrads since it was a TF, since the early 70s. Nice. And I taught Harvard undergrad, more or less on stuff from when I returned here in '83. And it's also something that the Indonesian undergrads will want, and the Indonesian medical schools will want.
Hopefully.
So one thing that comes out of this, and I want you to actually push this forward maybe in a supplement, is the cost of universal health coverage. Yeah. With quality. Yeah. And so people have access, but the problem with quality, and also the problem with payment. Mm-hmm. And this is true here in the U.S. So we're doing this study of psychiatry's response to cultural diversity here, and found that one of the things that happened, was manageable, but money trumped cover. And people yearn for free care. Remember, students have free care. You can make your own decisions as a clinician when you've had free care. Yeah. And for people who didn't have coverage. When the care went, chaos arose, and all the different systems. And so even though mass health was it's still a problem.
Yeah, I agree.
California has a disastrous problem with cows.
Yeah.
Indonesia,
Right.
everybody, everybody has a card if they have a residence, if they have a family. If they don't have a family, if they have a residence, they don't have a card. If they have a card, what do they get?
Yeah.
The greatest,
I mean,
not the greatest, not the greatest quality. Yet there is a movement for universal health coverage, and there's a movement to enhance quality. So really looking at the issues of quality is very important. I thought, put your in the university instead of in the tea parties.
Yeah.
And it's WHO holding those tea parties.
Well,
They went in to try and train community mental health workers. They have to sit in the tea parties for days and Indonesia, the specialists at doing this and wasting time and not really being on the ground.
Interestingly, and I point this out in the book, that actually not WHO. This came
in the case of the Indonesian case,
but
WHO.
But the whole per diem economy actually comes from the U.S. Foreign Assistance Act of 1961. Which, think about it, what's happening in 61, right? Nkrumah, Lumumba, Cabral, liberation struggles, this of socialist governments. And so part of the U.S., creation of USAID, and in that 1961 Foreign Assistance Act, it says you cannot fund recurrent costs of a government. In other words, salaries, supply chain, and all those things. So the U.S. is such a huge elephant in the room, and as is the sort of McKinsey's of all this kind of corporate mindset of privatization, that a lot of it comes from that, and then is imposed on governments, imposed on the WHO. So I think, we've got to look at where is that coming from. That is coming from this fear of the public sector, in my opinion.
Well, it's coming from the nature of the way those governments are structured.
Yeah.
So people are paid very little. They go to the training, they get some money.
Again, why are they paid very little? They're paid very little because of the wage bill, which is imposed by the World Bank and the IMF. So a lot of
that. It's also Dutch colonial.
Right, but I mean, a lot of it is the way that we think of funding the public commons. Right. And that is a very neoliberal construct. And so unless we move from that, and one thing I talk about a lot in the book, in the first chapter of the book, is the human rights framework. And I think the marginalization of social and economic rights by the Cold War ideology, the marginalization, so the idea that we think free speech is a right, voting is right, maybe. In the United States, maybe not so much. But other things are privileges. Like if a government can't hold their elections, we don't say, well, you're too poor to have democracy. We try in there and, help out. Now, again, that's a whole nother political morass, but nobody would say, in a poor country like Liberia, you need to have a user fee to get your ballot. But about health and education and water. And so, to me, that marginalization, which happened during the Cold War, is something we have to rebuild as the social commons. We think of some of these things as part of the public good, and we don't think of healthcare as part of the public good initially. So I think there's a lot of the
But those countries may think of it that way.
Absolutely.
So when we say we...
No, we being the dominant sort of narrative.
Maybe the dominant, funder of some things, but not necessarily. So it's an emerging discussion, and it's very, very interesting. And yes, USAID trying to structure how health insurance should be set up in Indonesia.
Yeah.
They tried.
Thank you.
They failed.
Yes.
I'm Pakistan.
Great.
I'm a visiting representative here.
Okay.
I'm working on negotiating tuberculosis.
Nice.
On this, I have a question and one comment as well. My comment is there is a difference of teaching methods and teaching techniques in the developed and the developing countries.
Yeah.
Instead of conducting the research through the process, I got to know, when I come up here, I got to know who the medical students in this country, there is a subject for ethics that is not being taught to the students of medical students of Pakistan, and but I assume about the other developing countries.
Yeah.
And I'm anthropology from Pakistan. However, we
I have been observing for the last 4 months here in a developed country and all debate. It is not teaching method in Pakistan. Our teachers take it granted, they do work with their pay. They don't work passion to give something new to the students. Like I've never studied a full book. I did not come up here. Yeah. We have been providing a little chapters, some of the notes, a lecture, that's it. Yeah. Not in detail. So this, I think, the book is very interesting, and I would request you to give me a copy.
Yes, absolutely. Yeah, look, we're relying on you. I mean, that's why we're here. This department is not a regular department. You know that. And that's thanks to Byron and Mary Jo and our 4 founders.
This is what I do believe. This is really understandable. Like the developed and the developing countries have really a different sort of teaching method and the approach. If the publisher has a notion or understanding to just teaching method as well among the undergrads, and this is really very interesting, fascinating idea. Rather, I have been working with NGOs as well, like putting on some tea parties, cannot we produce some sort of people who really
that's what we're working on. I mean, yeah, that's why we have our master's program here. That's what we want to do. Yeah.
And my question is, how neoliberal do change the public behavior? You did talk about that. I could not catch that word. You may do change the public behavior and the neoliberal. How do they change?
Yeah, I mean, that's a kind of in-depth question, but, about the time of the African liberation struggles, you have the writings of Frederick Hayek and Milton Friedman, who really believed that the market would fix itself, and any intervention of the public sector would distort the sort of wisdom of the market. And so it really called for a kind of extreme type of privatization, and that was really picked up by the World Bank and the IMF, and in the way that poor countries were funded, they had to adopt this extreme view of privatization. And that meant shrinking extremely the private sector. So and it's still happening. I mean, it happened in Greece, it's austerity. I'm sure it's happened multiple times in Pakistan and Indonesia, in any country, right? And so in the absence of the sort of public sector, then different things happen, different distortions happen. The distortion of people going to trainings to get a salary, to get a per diem. The distortion of private things popping up without
salary for the month.
Exactly. Often it's triple their salary. This distortion of unregulated health care, because regulation is also something under the public framework. So it really has served to, over decades, undermine governance. That's why I did the chapter on governance. I'm focused on the public sector rather than global governance, because trying to empower governments to be able to provide the functions of government is a kind of novel idea, right? Because they are being bullied by donors, by the bank, by, hopefully less the bank with Jim as the president. But I think the neoliberal mindset, and by the way, and what I was going to say, this department is unique, right? We're unique. Even in the medical school, we're pretty unique. We have teachers that are very passionate about teaching. We teach social science, which many medical schools don't have at all, right? And this is because of the legacy of our great faculty here. And, we are part of why we have the master's program, part of why we have PhD students here, is we want to change the way people think. Focus it on patients, focus it on sort of the justice, social justice, equity, etc. So I think that it's not just developers versus developing. A lot of the pedagogical framework is a very biomedical framework. The political economy of a biomedical framework is you leave out 50% of other people, right? Because it's the social structures and the structural violence that gives them their illnesses. So if you just use a biomedical framework, it comes with a particular political economy. How do I science? Good? Okay. Yeah. Aaron. Political economy man.
Okay. So my question is about, you kind of brought strategic vision. How does this kind of project act with more grassroots conscientization, imperatives?
Yeah.
In terms of
great question, Erin. I thought a lot about it because, again, it's a textbook, right? It has a market plan. And, but what I try to do throughout the book is in each chapter, whether it's the Human Resources for Health chapter or the MEQ chapter, is really talk about how different social movements have interfaced in this. So look about the medical monitoring and evaluation, which may seem like the most dry subject, and yet activists created open medical record systems. The Open MRS project was an activist project to say we should not pay a lot of money for medical records. And if we need to move into the 21st century, it can't be as a for-profit system. So each step trying to say, and it's my hope that people engaging in this will see some of themselves and some of their own struggles in it, and perhaps use chapters, use pieces, or use some of the case studies that are available online for free to sort of to help to do education in their own movements and or intersectionally across movements. That's my hope. But it's text. Yes, Byron.
So historically, it's very fascinating to think about when Palmer and PIA had existed in those early days with nothing to do with government.
Yeah.
Right?
Yeah.
And I'm interested, number one, in hearing a bit more, just like historically, about the transformation of your thinking to the model now. And then number two, there is a way in which to carry out the program you're talking about. You need the kind of $300 million a year organization that PIH is, et cetera. My question.
100. Not yet 3.
Okay. And but the question of like how smaller projects contribute to the same thing without taking the whole thing off, and how, for instance, one of our goals is to work primarily in the university, but make sure that work primarily in mental health, but make sure that they actually carry out their experiments in primary health care clinics, and they try to actually make a system work at that level, as opposed to going off and doing it in some private clinic or someplace.
Which is often easier.
That was funded by the Obama administration, by the way, where they, a university partnership, not only Harvard cities, but then the partnership with the local, with the Ministry of Health or with the whole healthcare system, public health system. So I don't know if they got the idea from PH or not, but it was really interesting funding for that.
I think it's a great question, Byron, and I would say, nobody, even PIH, we don't take on the whole thing. Right. I think it's much better to do something well and in depth than to spread your work like peanut butter. I mean, I think, across bread, because that's been the model for development and it's failed. So, I think using deep work to have a transformative effect, and then supporting the governments to figure out how to maybe take that on. And that's what's worked in Rwanda. I also would say that, what you all have taught me and, over the years, and I've learned, especially in Haiti, is, listening to the local people and what they need is the most important thing. Because, you come in with a million ideas, but it's not really relevant to people who you're surveying, you're working with, your colleagues. So I think developing really open relationships with people and, this whole mapping thing that came from Max's head. And, he would say, oh, yeah, we only have 30% facility-based delivery. And I would say, well, how do you know that? I remember this conversation in Wozo. It had to be 15 years ago, right? And I said, I got out a piece of paper and I said, teach me, tell me what you know. I could have come in with an agenda of doing this and that. He said, no. And because of that, he was working on it, right? So I think trying to listen, and that's so much a part of the social medicine context, not only to the patients, but also your colleagues, and where you've done that in your work in engineering makes it effective. The government before in Haiti, started as a medical charity and preferential option for the poor. It also started under dictatorship, the Duvalier dictatorship. It's not always entirely possible to work in the public sector under a dictatorship. Now, sometimes you can, and I think it was just a kind of a quiet decision. But one say is our work in tuberculosis, particularly, a lot of it in Peru, but also in Haiti, later in Russia and Kazakhstan, really showed us that there's no real way to get to equity without working with the public sector. And despite, like, the current government in Haiti is not a great government to work with, I would say, we're going to keep trying. And, you know, some would say in Rwanda there are issues with the government, but in terms of health, they're excellent. So I think what we realized from these kind of communicable diseases that everyone seemed to care about, that you really you know, there was no real way to have equity if you weren't in public facilities.
So a related question. Implementation by nature means change bureaucracy.
Yeah.
And it's something that's not one of the sexiest topics.
No.
To try to understand exactly how the bureaucracy works.
Yeah.
The first volume of a journal called Implementation Science, the first essay in it said, if you want to really try to understand something, try to change it.
Mm-hmm.
And what you discover, as you have many times, that by trying to change the health bureaucracy, you discover first all the reasons it can't be changed. And, like, how can, like, bring understanding of bureaucracy and how to change bureaucracy to bear on this kind of implementation?
It's a great question. It's not really an answerable question, but I can just give you one thought about that, because when we say at Partners in Health and even in your book about sort of public sector, it's very important to understand that none of it is monolithic, and bureaucracy is not monolithic. So trying to find one or two people who are advocates for change is sometimes enough. Sometimes enough. So I'll, give the example of the mayor of Mukherjee, right, who brought to bear the hospital that Maxie ran for its incentive. He really was a change agent. He wanted Partners in Health in Mukherjee. He, removed people from the existing moribund hospital. He chained it. He locked it. So, the Haitian government is still a messy, awful bureaucracy. But the participant of civil society and one public sector ally, really one public sector ally, what allowed us to put up a $20 million hospital in the setting of really extreme poverty without many death threats. Right? And so I would say that's one thing. So that sort of understanding that every bureaucracy is held up by individual people, and if you can find one or two people, you may be able to shake it loose enough to do something. The second, Maxie reminded me, because he's had so many death threats, and he's is Survivor, like the TV show Survivor. On an island, he's a survivor. Is jobs, like, to understand. Part of why Maxie was able to, and I give him personally a ton of credit for this, is how do you open a $20 million hospital in the setting of great squalor? Right? You have to understand the community, right? Walking around the community, people are asking for jobs. People want some benefit from that big thing there. So it's jobs, it's healthcare, it's to buy their chickens, it's whatever. But that proximity to the community is a way to get around the bureaucracy. No other major project was done after the Haitian earthquake, because a lot of the entities that are doing it have no knowledge of the social context. This is what I would say about bureaucracy: knowing the local social context, that local moral world, what is it that people want, and it's hard for us because we're field people, and we hear here, you have to have management skills. What management skills? Management skills might be buying 7 chickens from the niece of the mayor. That's your management skills. That's not recognized here as a management skill, but that is what it takes, right, to break through. Is that right? 7 chickens. The same management test. Okay.
So I think we're on the
All right, we'll end on the 7 chicken myth.